Good afternoon. I'm Dr. Jazz Atwal. I'm Manitoba's Deputy Chief Provincial Public Health Officer. Today, we are announcing one additional death due to COVID-19 from the Southern Health Centre Sud region. I want to offer my condolences to the family and friends of the individual identified today. The current 5-day COVID-19 test positivity rate is 9.6% provincially and 11.3% in Winnipeg. As of 9:30 a.m. today, 502 new cases of the virus have been identified in Manitoba. And the total number of lab-confirmed cases in Manitoba is 40,940. These numbers are alarming. Our case numbers this week are up 25% over the last week. In addition to the higher case numbers, we're seeing an increased case demand for admissions to the ICU and hospital. Of the 201 patients in hospital right now, 111 are under the age of 70. And of that 201, more than 30% have technically recovered from COVID-19, but they still require significant levels of care. We continue to see that people with an underlying health condition have more severe outcomes compared with those with no underlying conditions. As the numbers of cases rise, we will see more hospitalizations and more severe outcomes in Manitoba. However, case rates for severe outcomes are lower in those who are vaccinated. Rumors are circulating that there are more vaccinated people ending up in the ICU and hospital due to COVID-19. But Manitoba's data does not support that at all. Case rates for severe outcomes are lower in those who are vaccinated. Since we started vaccinating Manitobans in December of 2020, we have seen a gradual decrease in hospitalizations, ICU stays, and deaths due to COVID amongst those who are vaccinated in all age groups. In contrast, severe outcomes are increasing in unvaccinated individuals across all age groups, but especially those in the ages of 50 to 69 and 70 to 79. And hospitalizations are rising in people under 40. We encourage all Manitobans to book a vaccine appointment as soon as they are eligible to help reduce the stress on our healthcare system and bring case numbers down. Last week, we put stronger public health orders into place. And while it usually takes 2 weeks to see a significant change, it's worrying that case numbers keep rising. That's why meetings are underway right now to finalize new public health orders. Dr. Roussin will be speaking to this at 6 p.m. this evening. In the meantime, I can't stress enough. Stay home, reduce your number of contacts, follow the fundamentals. We're all tired of this pandemic. We're all tired of the public health orders and hearing about the fundamentals. But these actions work and they make a difference. We can bring our case numbers down and reduce the growing stress on our healthcare system. I have some updated information today about Dr. Roussin's comments last week on the B1617 variant in Manitoba. B1617 is a variant of interest. At this time, Manitoba is not undertaking specific screening for this VOI or any other VOI. In addition, CADM Provincial Lab is not aware of any jurisdiction in Canada specifically screening for this VOI. However, cases may be found through sequence surveillance or occasionally from further sequencing of unspecified variants of concern. At this time, we can confirm that there have been 4 cases of the B1617 variant of interest found in Manitoba that have been confirmed by sequencing. Based on current sequence surveillance or further sequencing of unspecified variants of concern, Manitoba is not seeing widespread transmission of this variant in the province at this time. Manitobans are reminded that different strains of COVID-19 are circulating in the province at any time, including variants that have developed in Manitoba, as well as variants from other locations. While some variants do have the possibility of transmitting more easily, there are precautions people can take to reduce their risk. We encourage all Manitobans to make their vaccine appointment as soon as they're eligible, to follow the public health orders in place, and to practice the fundamentals. Mother's Day is this weekend, and unfortunately, we are not able to celebrate the way we want. Now is the time to show Mom how much she means to you by not putting her at risk or those she loves at risk. Under the current public health orders, gathering indoors or outdoors on private property is prohibited. If you need to get together, go for a walk outside while wearing a mask or do a virtual gathering. Thank you. I will now pass it over to Chief Nursing Officer Lanette Siragusa.
Thank you very much, Dr. Atwal. I just want to do a check if everyone can hear me okay. Okay, I'm sorry I can't be with you today, but I've come with a lot of information, so if you can just bear with me, I will give you an update on as much detail as I possibly can, and I'm happy to answer questions afterwards. My goal today is to give you a really complete picture of how we are intending to create capacity in acute care to deal with wave 3 of the pandemic. For those of you who haven't seen me in a while, my name is Lanette Siragusa. I'm the Chief Nursing Officer with Shared Health. As of midnight, there were 201 patients in hospital who have or are recovering from COVID-19. This includes 40 patients who are under the age of 40. To give you a bit of comparison, there were 149 patients in hospital a week ago who had or were recovering from COVID-19, and that included 18 patients under the age of 40. There were also 118 patients in the ICU this morning, including 56 patients who have or are recovering from COVID-19, and six of the 56 ICU patients, COVID patients, are under the age of 40. Again, just to give you some perspective and comparison, last Friday there were 39 COVID patients in the ICU and 2 were under the age of 40. Wave 3 is here, and we are seeing this evidenced by our test numbers in our alternate isolation accommodations, in our hospitals, and in our intensive care units. We are seeing younger people in hospital who generally are in a healthier state than the patients that we cared for in wave 2. And while this may mean that the patients likely have a good chance of survival, certainly better than the older and sicker population who were ill in wave 2, they are still just as sick when they come to us for care. And many of them will require prolonged care within our hospitals. So this means that we not only need to create more capacity, but we also must prepare for a surge that may last longer because these patients may require longer care over a period of time. And we need to accommodate them as well as new patients who are admitted. So over the past 24 hours, we have begun activating a number of parts of the plan that have been in development over the last number of months. But I do want to be clear that wave 3 is different from what we have seen before. With each surge, we have learned and adapted our planning and our processes. We have also watched and consulted with other jurisdictions. So we have taken this time to prepare, but it's also important for you and all Manitobans to understand that this virus is changing and evolving, and it is our intention that our response will change and evolve as well, along with this virus. And while many of our measures that were implemented in the fall of winter in 2020 remain appropriate, there are a number of important factors that have informed our wave 3 approach. So one of these factors is the vaccine. Manitoba's vaccination campaign has immunized thousands of Manitobans, including many of those who were most vulnerable during wave 2. The vaccine has also been made available to every healthcare worker, which is an additional protection, an additional layer of protection to add to their normal protocols and precautions, as well as their personal protective equipment. We all know that COVID's second wave has had a devastating effect on our personal care homes, with more than 40 in declared outbreaks at the height of the virus. It has also had a significant impact on healthcare workers who either contracted the virus or who were exposed or had symptoms that required them to miss work. Wave 3
has the PCHs in a completely different situation at present. The very low numbers of active cases among the residents, because 95% of the PCH residents are fully immunized, this tells us that they are well protected. All PCH staff are eligible as well to receive the vaccine, and most PCHs continue to provide asymptomatic testing to their staff. We are also seeing an impact of the vaccine in terms of a benefit to sick time. So over the past week, the Winnipeg Regional Health Authority lost 5.24% of all scheduled work hours to sick time. For this same period last year, that rate was 8.27%. And in real numbers, what that means is 1,700 fewer 8-hour shifts are being lost to sick time now than at the same time last year. Staffing during a pandemic is an ongoing concern. However, these results are giving us some optimism that the vaccination efforts among healthcare workers is paying off. The second factor that I want to speak about is the variants. We are carefully watching the experience of other jurisdictions and have kept strict visitor guidelines and other precautions in place at all our healthcare facilities. And we remain vigilant, and we ask all Manitobans to do the same. We are asking Manitobans also just to hang on a little bit longer, to keep your contacts low, stay at home when you're ill, get tested if you have symptoms, and to get vaccinated as soon as you are able. It is safe, it is working, and it's really our only way out of this long lockdown. The third factor is surgery. It's an important factor underlying much of our planning. Surgery is a big program. There's lots of staff who work for the surgery program, as well as lots of beds. And we saw in the two previous reductions that occurred in elective and non-urgent surgery, which resulted in approximately 16,000 patients who had their surgical procedures delayed. And many of their cases now are becoming more urgent and less elective in nature. So we are keeping a very close eye on surgery, and as we go into wave 3, we are looking at how we can maintain as much surgical capacity as possible while still meeting the demands of patients who require COVID care. So for those of you who recall, when we were doing the wave 2 planning, we talked a lot about the 4 pillars, which were the foundation of our response, and that included having enough equipment, supplies, space, and staffing. And last fall, we shared that we have sufficient equipment, supplies, and space. We have sufficient equipment, supplies, and space to significantly increase our capacity across acute care, and this remains true today. And what also remains true is that the limiting resource in any pandemic plan will be and is our people, our staff. So Wave 3 preparation has focused on creating capacity in the acute system and improving patient flow, because creating capacity and patient flow just gives us that space, a bit of wiggle room, so when the COVID patients are coming in, we're prepared. So part of the creating capacity and improving patient flow, one of the strategies that we have implemented several months ago in December was what we call the Virtual COVID Outpatient Program, VCOP. And I did talk about this previously, but I'll just remind people, VCOP supports remote home monitoring for patients who are discharged from the hospital or patients who are seen in emergency, referred to VCOP, and don't need to be admitted. They are clinically stable patients, but do require follow-up from a medical team, and they may require home oxygen, so we provide them with the equipment, the oxygen and the equipment to monitor their oxygen levels at home. And then patients are then monitored by a clinical team during daily virtual visits and their symptoms and conditions are checked regularly. If a patient is experiencing any worsening of symptoms, paramedic may be dispatched to check on the vital signs, complete blood work, or maybe support a transfer to hospital if necessary. So this VCOT program was launched at HSC in December as a pilot project and has since expanded to Grace and St. Boniface Hospital in March, and has now supported 107 patients through the program, and in doing so saved 588 inpatient hospital days. 29 patients are currently in the program, 18 of whom are on oxygen therapy. And without this program in place, we would currently require an additional 28-bed medicine COVID unit. So it's been very helpful, and kudos to the clinical team who's been involved in that innovation. And it's been very successful. Another initiative that was launched in recent weeks has also seen significant results, and this is occurred starting on April 20th. The clinical teams in the hospitals as well as in the community throughout Manitoba began identifying patients, many of who were in the hospital, but also high-risk panel patients in the community, and identified who could safely be cared for in a personal care home. And these are patients who met the criteria and received an expedited placement in a personal care home so that that they could be transferred. And every effort was made to match individuals with their preferred facility. And in some cases, we have put them in temporary accommodation as they wait for their preferred location. And since April 20th, we have been able to transfer 205 patients out of hospitals and into personal care homes, as well as another 20 urgent clients from the community have transferred to a personal care home. Approximately 90% of patients moved from the hospital to the personal care home have also been placed in a home that's within their health region. And I really would like to take this opportunity to acknowledge my support of the personal care home teams, the operators, the managers, patients, and for sure their loved ones for supporting this initiative and recognizing that the personal care homes do offer appropriate care for the residents. It's an environment with a very high vaccination rate right now, ongoing preventative measures, and also the opportunity for loved ones who are involved in the care of the residents to be identified as a designated family caregiver and by that allowed to visit regularly. So we appreciate the flexibility and the cooperation of residents and their families during this time, and we are going to continue to work on these transitions. Our goal is to ensure that another 70% of our paneled patients in hospital are transitioned to personal care homes within the coming week. Also, surge planning for Wave 3 looked at efforts to increase critical care through Wave 2 and analyze what worked well and what opportunities were available to improve. And we certainly recognize the impact that this sustained surge has had and is having on healthcare workers. In the health system, we never really returned to normal. Many staff never saw the end of Wave 2. As you know, our critical care capacity was sustained at a higher rate than it was prior to the fall. And staff are tired. And the prospect of a third wave, particularly with the numbers that we are seeing now, is extremely stressful. And our plan is limited by the ability to keep our healthcare workers healthy. Disrupting their work lives, their personal lives again for redeployment to transfer them to another area or another facility is not easy. And it's also why we really need Manitobans to help us stop the spread of the virus. Since the beginning of Wave 2, our staff have taken the time to share with us ways that we can improve our support for them when they are redeployed to other units, such as critical care and medicine. And one of the biggest changes that came out of those conversations is an enhanced orientation period for staff who are new to these areas. And I have to say the conversations have begun with staff, and they will continue, but I've just been so impressed and inspired by the staff who are accepting the call to join the critical care team and commit to taking care of Manitobans' sickest patients. It's quite amazing. In the last month, our most recent critical care nurse orientation program graduated 39 new critical care nurses. Since April 2020, 130 nurses have graduated through the program and are working in the positions they were hired into at the start of their training. And following discussions with our nursing leadership and our nurse educators, our focus for the current critical care nursing orientation program shifted to more of an accelerated orientation so we could be prepared, prepare our staff for what we anticipated would be a patient surge tied to the third wave. So this accelerated orientation offers nurses a 2-week orientation to work in critical care, including a blend of complex critical care theory, technical, practical lab skills, and clinical orientation in a buddied learning environment. The orientation has been built to reflect the feedback and lived experiences of our nurses who were redeployed to work in ICUs during Wave 2. And since last month, 23 nurses have completed this program, with another 17 set to start over the coming weeks. Further efforts are underway to recruit more interested nurses. We recognize that these additional resources will be required over the longer term and in potential future waves. We are preparing for that, and we are very happy to report that in support of a longer-term strategy, we are adding 60 full-time equivalent nursing positions to the system for nurses who wish to work in critical care. And these positions will be posted in Brandon, as well as at the Grace, HSC, and St. Boniface. And once these nurses are hired, they will support an increased bed base for the foreseeable future. At Brandon and the Grace, this will equate to 12.6 full-time equivalent positions, or 3 nurses at each site 24/7. St. Boniface and Health Sciences Center will increase 16.8 full-time positions at each site, or this could be also equated to 4 nurses at each site 24/7. So this is a longer-term solution. This isn't going to meet our immediate needs, but it is one that is very important to our overall management of potential future waves, because we think those are still ahead of us. In the future, this will enable us to support a higher number of very ill patients and maintain other essential services like surgery. And as cases climb and hospital admissions rise, we are moving to open a number of additional critical care beds in the coming days. Our critical care capacity will remain at the 4 hospitals that house the intensive care units. Again, those are Health Sciences Center, St. Boniface Hospital, Grace Hospital, and the Brandon Regional Health Center. Over the next few days, these facilities will expand their critical care footprint to include an additional 19 ICU beds. And while our efforts to train and recruit new critical care staff over the recent months will definitely help to support some of this expanded capacity, in order to staff these beds appropriately, we are going to have to make the difficult decision to reduce clinical activity in some places. With the current case positivity and increasing hospital and ICU admissions, While we continue to prioritize emergent life and limb, trauma, cancer, and cardiac surgeries, we are going to have to look at all surgical activity very carefully, and we'll be prioritizing on a day-by-day and case-by-case basis. Other services, including some medicine patients and some surgeries that can safely be supported outside of our acute facilities, may need to transition to other facilities, including those outside of Winnipeg. This means that we are looking at shifting where we deliver some care, including some surgeries, potentially shifting where some patients will receive their services, and every consideration is being made to ensure that we continue to meet all clinical standards and patient safety requirements. The impact to surgery in the coming weeks is likely to once again be significant as we reduce surgical volumes to allow for an increase in critical care capacity. And patients whose appointments are affected will hear directly from their care team if there is a change in their appointment or their care plan. So I'm just about done, but I just want to give some detail on the additional beds for critical care and what this looks like. So the plan for additional beds at HSC, there will be 6 additional ICU beds at HSC, which will bring the site's critical care capacity to 58. This is an increase of 19 beds over the site's normal ICU base. This change, this shift, this increase will be accomplished by shifting staff already working in other areas of the site, ramping down some less urgent surgeries at the site, and redeploying some staff from across the system. At the Grace Hospital, another 4 beds are expected to open, bringing the site's critical care capacity to 16. And this is an increase from the site's normal ICU bed base of 10. This will be accomplished by a reduction of surgery at the Grace Hospital. Urgent cases will continue to be prioritized, and some activity to support orthopedic trauma may shift to Concordia Hospital. At St. Boniface Hospital, where our province's cardiac center is located, we do want to ensure that cardiac remains a top priority. So we continue to look at opportunities to increase the critical care bed base by further expanding into the recovery room. And that work is ongoing, but ideally we would increase capacity by another 14 beds to include a total of 28 critical care beds at St. Boniface. Again, this does not include the cardiac ICU, which we will continue to support cardiac patients. And finally, in Brandon, efforts to increase critical care capacity from the current 9 beds to 13 beds is underway. This is what we did in Wave 2, and it has required a reduction of surgical slates by 50%. So that we can use the space as well as reassign the staff to support the critical care. And this, as I said, was very similar transition to what Brandon supported through last fall and winter. And finally, with the increased cases of COVID-19, we do anticipate further demand on both our alternative isolation accommodations and on our emergency departments. We have 18 alternative isolation accommodation locations across the province with a current occupancy of approximately 52%, and it's variable at the different sites depending on where the community spread is happening and the outbreak. So some sites are quite full, but others have capacity to help. And these facilities, just a reminder, are voluntary isolation spaces so that people can isolate. And we also use our VCOP program to support individuals who maybe don't need to be in hospital but do need to be in a safe spot. We continue to receive significant volumes of patients who are presenting to the hospital and also shifting some resources to support patient care and improve flow in our province's largest and busiest emergency department. So at HSC, Adult Emergency Department, ambulatory care staff, the clinical staff who work at HSC, are being asked to work or be reassigned to the emergency department to support low acuity patients who are more primary care almost, primary care activities, and work with these patients to follow up on diagnostics, lab results, or consultations. The other change that we're implementing starting next week is that Children's Emergency at Health Sciences Centre, their volumes have continued to remain lower than their normal baseline. So they will be preparing to welcome older adolescents up to the age of 19 years old who require emergency care or an admission to an inpatient ward or the pediatric ICU. So we anticipate these changes coming early next week, and we will keep public informed of updates in the coming days. And in an emergency situation, of course, we do want to remind all Manitobans to seek emergency care by calling 911. So in conclusion, we will increase capacity in phases as the demand requires. However, what we have seen over the past week has us implementing an accelerated implementation plan in a number of areas. Local and site-based input is contributing to each step of our approach, with a provincial team supporting and overseeing the work to ensure we are consistent across all regions and meeting the needs of all patients. Our plans will evolve, and the variants will require us to be innovative and continue to push through the fatigue that all healthcare workers are feeling. And I know Manitobans are tired too, and I want you to know on behalf of all healthcare workers, we are committed to taking care of you if you need us. The healthcare workers continue to step forward. Their professionalism and compassion shines through, even at their most tired and in their most difficult moments. Our ability to increase capacity relies upon our available health workforce. Healthcare workers will continue to do whatever is required to care for their patients. But our ability to increase capacity takes a toll on every area of our healthcare system and on every staff member and every patient. None of these efforts are a replacement for our responsibility as Manitoba citizens to follow the public health measures, and we really need your help. It's been 14 months, and many of us are tired, but doing everything right, and we need to continue to do our part. Wash our hands, wear a mask, get tested if we have symptoms, and get vaccinated when available, when eligible. So I just would like to thank you all for your time. I'm sorry that was very long, and I'm happy to answer any questions you may have.
Thank you, Chief Nursing Officer Siragusa. A reminder to our reporters on the line, you will have one preliminary and one follow-up question, and please remember to mute your devices when not asking questions. Up first this afternoon from CBC Manitoba, Bart.
Hi, Ms. Siragusa. There is a little bit of a discrepancy between the information this morning and what we're hearing from some nurses on the ground. They're saying that they are being deployed to ICU, not just by volunteering. They're just being redeployed there. Earlier, we were told by one of your colleagues that this was voluntary at first. Can you clarify on how nurses are being redeployed into the ICUs at this point?
Yeah, our intention was definitely to seek volunteers. That is my understanding of where we were at. I have not been told that anyone has been mandated at this time. That's always an option as we get further into the demand and the demand increases. but I can follow up on that, Bart. From what I know, we were just starting the conversation and we were talking about volunteers.
Thanks. Next one's for Dr. Atwal. Dr. Atwal, I'm going to ask you a question I asked the Premier earlier today, and if you look back at the numbers on approximately April 14th, you can see the exponential rise back then, and even a layperson can see the shape of the curve. So, looking at the numbers then, they indicated numbers like we're seeing now. Pretty much exactly that. And then we're seeing the hospital patients to follow. So why didn't Manitoba simply do the circuit breaker approximately April 14th?
That's a great question. So when we're looking at models, when we're looking at our numbers, I mean, the orders were in place at that time. We had restrictive measures in place. We were messaging to Manitobans to adhere to those orders, to do more in relation to the spirit of the order as well. Orders are there for people to comply to, but if there's little adherence to it, obviously, the case numbers do rise. There's more interactions between people as well. So as we saw the case numbers rise, last week we enhanced our restrictions. So, even from before last week, we had fairly significant restrictions. We added in some greater restrictions. And it's been, 8, 9, 10 days now since those restrictions. Obviously, we're hoping for our case numbers to come down. We've always expressed that we want to put the least amount of restrictions on individuals, on people. But it's coming to a point here now that we're seeing that, with these even significant restrictions we have in place, we're still generating lots of cases. And there's various different reasons for it. One is there's a lot of transmission out there. There's community transmission out there. Number two is we have restrictions in place. People aren't adhering to the orders, which is contributing substantially to these case numbers as well. So our cases have gone up, roughly 40% per week on a trailing average since April 7th. Our ICU numbers have gone up in relation to COVID specifically, about 15% as well since April 7th as well on a 7-day trailing average as well. So, we were analyzing this data on an ongoing basis. We deal with our acute care colleagues on a regular basis as well. And now is a time that we're going to have to take that next step. So we are finalizing some significant changes to the orders that Dr. Roussin will speak to later on today at 6 p.m.
From the Canadian Press, Steve.
Dr. Atwal, as you mentioned, these numbers, including the raw case numbers and the test positivity rate, are alarming. Are the real numbers even higher? And I ask that because we learned this week that there have been some delays in testing. There's a surge in demand for testing, and there's been an equipment problem or two. So are we still seeing that delay to 72 or more hours for some test results? And what does that mean for the possible real number of new cases?
Yeah, so we've seen case numbers increase in every jurisdiction on a rate basis. The NRHA, the Northern Regional Health Authority, outside of a couple of communities, their case numbers are actually coming down. And I think that has to do with vaccine rollout and them being in a tough spot for a long period of time as well with case generation. So Winnipeg is the major center here, the major region where we're seeing a lot of case generation, but we do see all those numbers creeping up right across all the regions, especially in Prairie Mountain Health and let's say Southern. So earlier we did have a bit of a stress test, you could say, on our testing and our testing turnaround. There was a little bit of a delay here where there was a computer issue that had an effect on our turnaround time. Our turnaround time, on a median turnaround time, was about 48 hours. We understand about 5% of individuals that did exceed to about 72 hours or a little there afterwards. So those things have been repaired. The issues there on the technical side, on the computer side, and the IT side has been repaired as well. So definitely our testing capacity is being stress tested, as is our case and contact management, but there's no signs of any cracks or failures, I would say. So we are getting back. Our numbers are improving on the testing side for turnaround time as the IT issue had been resolved as well. So we're seeing valid information. We're not seeing those delays, really. There are some one-offs right now, obviously, but in general, we're getting the majority of our tests back in a timely manner, and our case and contact management is happening in a timely manner as well.
Okay, and Ms. Siragusa, you testified in court this week about how when ICU beds were occupied to the point of about 129 people during the second wave, that the system was being stressed at that level. what is our current ICU capacity for all patients right now, and how bad is it forecast to get under the modeling you've seen?
Well, we've been planning over the last many months based on what we saw in Wave 2. And the peak that we saw in Wave 2 in the critical care ICU units was 129 patients. So we've been gearing up for that at minimum or at maximum, however you want to look at it. That's been our line in the sand working number. And we are getting close to that now. And the numbers that we're seeing come in admitted to ICU, especially this last week, have been high. And when we look at if we sustain those high admission numbers over the next days, not even weeks, we could reach that number. Now, there are a few differences compared to Wave 2. As I said, we are seeing a younger population. They're still sick, for sure. They still need critical care. But we have to see what that brings, if it brings longer length of stay or what the impact will be in terms of their outcomes and disposition. And the other factor is the sick time for our staff. So during Wave 2 and Wave 1, for that matter, we lost a lot of staff due to sick calls because there were outbreaks happening both in the hospitals, the personal care homes, and even in the communities. So we'll have to see if that helps us going forward. And we're always very cautious, and we're trying to support the staff as much as we can in maintaining just the physical, emotional, mental, physical, or spiritual efforts that go into serving people during this pandemic.
From CTV Winnipeg, Michelle.
Hi, this question's for Lanette. Could you describe a little bit how quickly the admissions have gone up into ICU? Like day over day, how many people are being admitted and what is the rate at which it's going up?
Yeah, so the first, we've been watching it, obviously. We watch it day by day. Sunday was our highest admission rate to date. Last Sunday, we had 10 people who were admitted to ICU in a 24-hour period. And throughout the week, we have seen 5, 6, 7, really probably an average of 6 or 7 patients admitted every single day in the last several days since Sunday. So it seems like a pretty consistent trend. And again, we watch. We hope it goes down. Or it could sustain that, or we're going to watch to see if it goes up. But those are the numbers we're looking at now.
Thank you. I'm just wondering what the difference in strategy is with surgeries. It seems like in the first and second waves, we kind of heard from public health saying we're postponing surgeries starting today. But what's different this time? Like, have any surgeries been postponed or canceled already? Have you already started with that? Have you started shuffling things around? Describe the difference.
Yeah, so in Brandon, I believe on Wednesday, they decreased their surgery activity by 50% so that they could increase their critical care activity. So that happened as of Wednesday. And now we have many priorities, but the decision has been made that we will be decreasing surgical activity at the Grace because they need more space at the site for critical care as well, space and staff. So that's going to happen. And I think, in the first and second wave, when we decreased surgery, we allowed people to proceed, and of course they were looking at where are the priority patients, what's life and limb, what's urgent, what cannot be delayed, and we would proceed with that. We're taking just a heightened approach, given that we have already now a wait time or a wait list of 16,000 people potentially. So when they wait that long, what was once non-urgent and elective, some of those things become more urgent and not elective. So we really need to be careful with that. We want to, wherever possible, maintain, sustain the volumes. The teams have done very well in between wave 2 and wave 1. At many sites, they got back up to 100%, not all, but many. And as we go forward, we're looking at, can we shift some of the surgical activity potentially outside of Winnipeg to maybe a neighboring hospital? So we did that a little bit in the second wave, but we're looking at more opportunities now. And we're making sure that we preserve those really acute and high priority surgical cases.
From City News, Mike.
Good afternoon, CNO Siragusa and Dr. Atwal. My first question is for Dr. Atwal. With 500 cases announced today, obviously we're going to see that kind of taper off once these restrictions start to take effect. But do we have modeling that shows us what number we should start expecting by the time that it starts to dip, just so Manitobans can kind of anticipate what number it'll see?
I don't have a specific model to that. Obviously, when restrictions come into place, we're going to see case generation still, so it still should grow. So our 7-day trailing average, is about 320 cases right now. So I think that'll continue to increase over about a week's time. And then, with greater restrictions in place, that should plateau. We should see a decrease there afterwards. So I don't have a specific model, but that's typically the pattern that we've seen in the past and in other jurisdictions.
Thank you for that. And my next question is for CNO Siragusa. Just some clarification on something from this morning. With 60 new permanent ICU nursing hires, do we currently have the staff to deal with the third wave, or are some of these support because the system is currently overwhelmed? Just looking for clarification.
Well, it's a rapidly evolving situation. Work has been done to build up that staffing capacity in the past weeks and months. So, and as I said, we have recruited and trained several nurses. 39 have graduated. More are in the program now. More are starting soon. But we will continue to seek out people. The 60 new positions is not an immediate fix. That's not what it's intended to do. It's intended to sustain us longer term, moderate and longer term, as this COVID continues to evolve and we learn to live with it. It's hard to say, yes, we feel like we're okay right now. We, as discussed, there's people volunteering, there's people being redeployed from other sites to the acute care, critical care units. And it really depends on the pace at which we're admitting critical care patients, if our staffing levels can keep up with that. So that is our biggest challenge right now.
From CHVN, Taylor.
Hi, good afternoon. Dr. Atwal, can you just speak to why we're seeing more cases and hospitalizations, even though we do have more people who are vaccinated?
Yeah, that's a great question. We're seeing a lot of activity in younger populations. So, the majority of our cases, I believe 70% of our cases are in those less than the age of 40. We have our most senior population vaccinated, so obviously we're going to see some less cases there. We're going to see less hospitalizations related to that as well because of the vaccination, because of the protective effect. So initially during the pandemic, once vaccines rolled out, we targeted those at most risk, and we're sort of graduating that down to get to the rest of the population. So our age drops down to the age of 40 today for booking appointments for a vaccine, but that does put a different population at risk. So even 4 or 5 weeks ago, we were seeing a greater number of patients who were cases a little bit older. Now we're seeing that shift come down to younger populations. There's a lot of interactions between younger individuals, with activities, out-of-school activities, and the adherence to the orders in those situations as well. So the shift is happening because of that, because I think we're vaccinating most, the oldest, where it prevents that infection from happening, prevents that hospitalization, prevents that ICU, but now we have that shift downward. We also, I think, are seeing a lot of community transmission. So that community transmission is occurring in families, with neighbors, with communities, and we're seeing a lot of clusters related to communities as well. So people interacting outside, coming indoors, or interacting, sharing food items, etc. So we're hearing a lot of those stories as well. So we're seeing a lot of transmission in younger populations because of those reasons.
Yeah. How, when it comes to the younger people in this community transmission, how is that still happening in Manitoba?
Just one more, a little bit louder, please.
How is this kind of community transmission still happening, especially in younger people in Manitoba?
Well, again, it's about listening to the messaging, right? We have restrictions in place to limit interactions in controlled environments, right? If you're going to an activity, the activity is controlled. A school environment is controlled. Restaurants, let's say, are controlled. Retail is controlled. But what happens on the way to going to these places? What happens after school, at home? What happens during these sleepovers? What happens during neighbors visiting with each other or family and friends visiting indoors? So it's the adherence to those orders in those circumstances that is important. And also those interactions that people are having that poses that risk. So it's not per se the activity where that order implies, it's more that social gathering outside of that. So the social gathering to go do something or the social gathering in one's home that is driving up case numbers.
From the Winnipeg Free Press, Danielle.
Hi there. My first question is for Lanette and perhaps Dr. Atwal as well. I was wondering if you can say what the ratio of hospitalization to case counts is currently, and with respect to people presenting at emergency rooms with COVID-19, what kind of volumes are you seeing and what do you anticipate going forward?
Dr. Atwal, do you have those stats off the tip of your tongue?
I'm sorry. We do have information on ER presentations that are respiratory related or COVID related. We do have some information on admissions. I don't have those numbers off the top of my head, but I do know week by week over the past few weeks, we've seen a substantial increase in those that are hospitalized. So you could see that increase happening. 50% of hospital admissions in the last 7 days appear to be in those less than 50 years of age. And I think we've had about 100 hospitalizations in the past week in total. That includes all hospitalizations in Manitoba that are COVID related. Those are the numbers that I have.
Okay, thank you. Thank you very much. And Dr. Atwal, while vaccinated individuals are not going to hospital as frequently as others, can you say what proportion of recent cases are among people who have been vaccinated and how vaccination will factor into your planning with respect to new public health orders?
We've got some really good data in other countries and some other jurisdictions in relation to the effectiveness of the vaccine to prevent hospitalization, to prevent ICU stays. We're gathering that information right now. At an early cursory review, there's a substantial difference in those who are 2 weeks post their first vaccine on admissions to hospital or presenting to hospital. So we know the vaccine is effective. I don't have those specific numbers at the present time. We are going through all of our hospital admissions, and we're going to be compiling this information to look at vaccine status, vaccine in relation to hospitalization or presentation to the hospital. So I don't have that information yet. We're hoping to have something in relation to that next week.
From Global News, Anya.
Hi, good afternoon. Are there still any patients in intensive care or in hospital in general from the second wave?
I don't have the details of that. Lanette, do you have any details on that?
No, but I can find that out for you, Anya, and get back to you.
Okay, that'd be great. Thank you. Second question, probably more for Lanette. Can you elaborate on what it means for staff to not see the end of the second wave while moving into this third one, whether that's the emotional toll or the workload or both?
Yeah, for sure. So as much as we tried, we made every effort to move our staff, our nurses, back to their home units.
And in many cases, that was successful. So nurses who were working in the personal care homes went back to their primary care or home care positions. Nurses who were in ICU maybe went back to surgery. But our baseline beds in ICU is normally, provincially, 72. So we have been hovering around 100 patients, 100 ICU beds since wave 2. We've never gotten back down to our baseline. We've just been hovering high 90s, mid to high 90s, 100 patients every day. So that does mean that patients or nurses and other staff have had to stick around ICU and support the teams and support the patients, which it's so appreciated that they have. Their contributions have been amazing, and obviously we couldn't do what we do without them. But it's hard, living, watching, being part of critical care during a pandemic. Some of our staff have never been exposed, never seen such sick patients. They've never seen so many deaths, and it is very emotional. It's hard. It's traumatic for some of them, and these are the lessons that we learn going into wave 3. Is how do we make sure that we prepare them the best we can, given the time constrictions? How do we make sure there is mental health support for them, and they know what to look for and who to ask if they need help? So these are all the learnings that continue as we evolve through this pandemic.
From CJOB, Skylar.
Hi, thanks for your time this afternoon, you two. Lanette, just building off of that last answer, actually, is the province ready for a different type of staffing situation, not where staff members are getting sick necessarily because a lot of them are vaccinated, but they just can't work either for those mental, emotional, physical exhaustion reasons. Is the province prepared to address that and make sure those gaps are filled as we go into this third wave, since the second never really ended for that?
Mm-hmm. Yeah, so we have our mental health team. Has been working since before wave 2, but I think they've probably learned some lessons and heard some ways that they can improve access to their services. And really, it's like nothing we've ever experienced before. So certainly our teams across the province are developing strategies, and they're evidence-based, and they're intended to support the clinical provider who's in this environment. Also making sure that the individuals who come and work in critical care have that ongoing preparation in advance, and the mental health part, but also the clinical part, like what do all the alarms mean, and when do you call for what? And they're doing cardiac rhythms, they're learning that, and they're doing it in a skills lab, but they're also doing didactic training on the unit with their buddies and real patients. So just making sure we set them up for success. That's the most important thing. We heard from nurses that they need that, and so we're committed to that. And still looking at team-based care where it's appropriate, but just appreciating everybody's role in this.
Thank you for that. Dr. Atwal, this one's probably likely more for you. We got to a certain stage in the pandemic where it wasn't about the new daily case number as much as it was about the 5-day test positivity rate. That was kind of how you saw the trends in the beginning. Will we get to a point either now or soon or sometime in the third wave where the test positivity rate starts to matter less and less because those cases aren't turning into severe outcomes as much as they are right now, or they were in the second wave?
Yeah, so during the second wave, obviously we didn't have vaccinations. During this wave here, we also have something that's a bit more communicable and something that might be causing more hospitalizations because it's a little bit more invasive in someone as well. We also have, with the vaccine rolling out, it really changes the ability to look at risk at a population level, because those who are vaccinated tend to, if they do get a COVID infection, tend to have a less severe infection. A lot of studies show that it prevents hospitalizations altogether, depending on the person. So, we're always looking at indicators. We don't just look at one indicator. We never just looked at two indicators. There's a number of indicators we look at. So we're looking at case generation. We're looking at, test positivity. We're looking at the age groups that the cases are being generated in as well. We're looking at vaccine uptake. We're also looking at hospitalizations and ICU numbers. That is sort of one of the most important indicators to look at, including mortality. Mortality has declined quite dramatically now since we're able to vaccinate a lot of our elderly individuals in society. So the acute care numbers are really important right now to look at. And we're going to continue to kind of monitor all those indicators and use them together to make decisions and to advise the public on.
From the Winnipeg Sun, Glenn.
Good morning, Glenn Dawkins from the Winnipeg Sun. We've had several of these protests and rallies over the last several weekends. Have you been able to trace any of the cases or outbreaks to them? To those rallies and protests that we've been seeing over the last couple of weeks.
I actually don't have that information.
Nor do I.
All right. Well, I know, Dr. Atwal, you talked about a rumor that you were trying to dispel earlier. Has that become a frustrating part, that there are rumors and they seem to take on a life all of their own? Is that a frustrating part from a public health standpoint, having to say this is not true?
Yeah, the misinformation out there has been a problem. I think it's a problem before the pandemic as well. I think we live in a society here where a lot's driven on social media, where a lot of people think they're experts by reading one thing or posting something and then someone else follows them. I think the pandemic has exacerbated that a little bit. And we've had misinformation all through the pandemic. And obviously it is frustrating. We're scientists. We're here to help the public. We're here in charge of a system, a public health system. We have an acute care system as well. It's very important for us to get good information out to people, and that's why we keep telling people to go to trusted websites, to listen to trusted individuals who are experienced, who have the knowledge to provide to them in relation to anything that might be related to the pandemic. If you want to learn about coronavirus, if you want to learn about vaccinations, don't go to social media. Go talk to your primary care provider. Go talk to your pharmacist. Ask public health those questions directly. That is the best way to get that information. So it is frustrating. I think we're dealing with it on an ongoing basis. I'm sure we're going to have to continue to deal with it as well. But we're hoping that Manitobans do reach out for solid, scientifically based forms of evidence to make sure that they're aware and make good decisions based upon that.
Our final reporter this afternoon from CBC Radio Canada, Laisa.
Hi, Dr. Atwal. My first question will be, you mentioned that now we have 111 Manitoba that are under 70 to the hospital. Do we know how many of them maybe have are under 40?
In relation to hospitalizations is what you're asking?
Yeah.
Yeah, so I know in the past 7 days, 50% of our hospitalizations have been in those in less than 50. And I would say probably, I have to look at that number to get you an exact number, but those under 30 contributed probably, up to 2/3 of that number. So there's a substantial amount of young people ending up in hospital right now with COVID-19.
And this question will be for Lanette. You mentioned earlier today during the technical briefing that the province also looking to be moving a patient from one region to another. And where are the regions where a patient will be more likely to be moved, and why?
Probably we will be looking at hospitals that are fairly close to Winnipeg if we're going to be redeploying urban people rural. But those discussions will be with the regional health authorities to talk about what capacity they have in terms of their own space and staffing and equipment, and we'll work with them to make sure that there is a safe, welcoming environment for our surgical patients to go to. But preferably it would be somewhere not too far away, but a little bit out, but not. It wouldn't be like a plane ride away or anything, I don't think.
Thank you.
Thanks, everyone. That concludes today's media briefing.